So much for joining us. My name is Precious Green. I'm the Director of Programming here at Manny's, and we are in a state of emergency again. As you all know, the city of San Francisco has declared a state of emergency for monkeypox that went into effect today. And so we have another major health issue, a public health issue that we need to understand, talk about, and just make sure we're well informed so that we are doing things that are helpful and protecting of ourselves and not doing harm. So we really appreciate you all joining us today. I'd like to introduce our amazing panel of guests. First, we have Dr. Monica Gandhi. She is an infectious disease specialist and professor of medicine at UCSF. She is joining us from India, which is amazing. We also have Liz Highleyman, a health journalist and science writer who has written about HIV, women's health, cancer, and infectious diseases, again, like HIV and COVID, for more than 20 years. She is currently in Montreal at the International AIDS Conference. Finally, we have Andy Stone, who serves as the Senior Community Mobilization Manager for the SF AIDS Foundation. Thank you all so much for joining us this afternoon.
Whatever it is where you are.
Yes. Thank you for joining us this day. So, Dr. Gandhi, you brought the information we want, the actual science and the facts. So we're going to turn our screens over to you. Dr. Gandhi has a slide presentation that will be a few minutes, and then we'll follow up with questions. And that will be your opportunity, audience, to type your questions into the chat for me to ask our guests. All right, take it away, Dr. Gandhi.
Well, thank you. Yeah, I wanted to just give, a few kind of facts and the epidemiology and where we are in this global health emergency, which was declared by the WHO on July 23rd. So in terms of what monkeypox is, we're just going to talk briefly, what is this virus compared to what we've just been through with COVID-19 and what we all work on, which is HIV? What does the virus usually do in kind of what we used to call endemic locations? What is the epidemiology of the current outbreak that the first case was reported to the World Health Organization on May 13th? What are symptoms and how do we control this? What does it take and where are we in our attempt to contain this outbreak? So in terms of what kind of virus is monkeypox, just to remind us, the way that we classify viruses actually have to do with the envelope around them, but also what kind of genetic material they contain. That's the main way that we classify viruses. Is it DNA? Is it RNA? Or actually in the case of HIV, is it RNA, but then it goes to DNA. And so monkeypox is a DNA virus specifically. It's just as a reminder and contrast, HIV is a virus which is called a retrovirus. It contains RNA, and then it makes that into DNA, and then that gets into our host cell chromosome, and SARS-CoV-2, COVID, is an RNA virus. So monkeypox is a DNA virus. It's a member of the Pox viridae family of viruses. It's specifically called an orthopox virus. That's the family, that's what the family is called. And the subset that its relatives, its cousins, are smallpox, which used to be called variola virus, which is now eradicated worldwide. It's been eradicated worldwide since 1979, 1980, eradicated in the US since 1970. Vaccinia is its relative as well, and cowpox virus. So these are monkeypox's relatives. And when did we start, when did monkeypox first get described? It first got described in 1958. There were actually two outbreaks that were in monkeys that were being used for research, and that's where it got its name. But monkeys are not the major carriers of the disease. Actually, rodents are the major carriers of the disease in, quote, endemic areas. What does endemic area means? Prior to this outbreak, where did we used to see it? Now, we didn't see monkeypox developing in any great extent, between 1958 and 1970, because we were all being vaccinated for smallpox. And then we stopped the smallpox vaccination campaigns across the planet because we didn't need to vaccinate people for smallpox. It was eradicated. And it was really with the waning immunity from not having smallpox vaccination that we started seeing monkeypox outbreaks. And this is a paper from the CDC that looks at outbreaks that occurred between 1970 and 2017. But really the majority of the outbreaks in West and Central Africa have really occurred over the last 10 years, which kind of makes sense because the new generation of people had never seen smallpox vaccine before. And there are absolute outbreaks in Ghana and Sierra Leone and Nigeria and other countries of Central and West Africa. There's a clade that's more virulent called the Congan clade. And then there's the West Africa clade that's usually more mild. And there have been absolute outbreaks in all these countries. So when we talk about, and I know Liz will talk about this, when we talk about global solidarity, when we talk about vaccines, this was always an area of the world where people have actually been suffering from monkeypox. Okay, so how does it usually manifest in the United States before we get to where we are now? Well, prior to this, again, in the West and Central Africa outbreaks, it's usually from exposure to rodents, like either touching them or being bitten by them or being exposed to an infected animal. And then in the United States, we usually see it when people have been infected in West and Central Africa and then travel back to the US. There were 2 cases in 2021 from cases where people had traveled to Nigeria. Importantly, in this case, there's been a lot of misinformation that it can spread readily. Importantly, one of the cases, they did 200 contact tracing of anyone on the plane, anyone they'd been and this person had been exposed to, and there was no other infections with this returning traveler in Maryland. So in 2003, that was the biggest outbreak we had in the US, and that had to do with rodents. There were actually a group of rodents that were kind of illegally imported here from Ghana. They got mixed up with pet prairie dogs in the Midwest. And then people bought these pet prairie dogs, and then they were exposed to these infected animals, and there were 71 people who got sick. No human-to-human transmission. That was all from exposure to the prairie dogs themselves. The median age was 28 in that 71-person outbreak. That gives you an idea in 2003 that they would never been seen smallpox vaccination. So this what we're going to talk about now, which is this outbreak, is really unprecedented, because what I've just told you is all about rodents and exposure to endemic areas. This is a totally brand new thing that's happening. So what's going on with this outbreak? Again, May 13th was the first case that was reported to the WHO. And now we're at, and I really would refer you, by the way, to this website on the bottom right, monkeypox.global.health. We're now at 22,000 cases in 94 countries of this outbreak, where the first cases were in the UK, then quickly in Europe. There may have been some Spain and Belgium rave involved, and then Canada, Australia, and now the US actually has the highest number of cases of this worldwide outbreak. It really absolutely is an outbreak that is occurring in men. If you look at the global health monkeypox outbreak, you can see that there's just very few women who've been infected, very few females, probably 98% men. And it really, the majority of the contact, the majority of the spread seems to be occurring through sexual contact, close skin to skin, close respiratory contact, not casual respiratory contact. You can, in a household, if you're have active lesions, you can infect someone in your household. So that's true of herpes as well. So there have been 2 children that have been infected in per the CDC from probably just close, contact with children in the household, but the majority of it is sexual transmission. And now the US is leading the world in cases. You can see we've had a 99% increase in cases from last week, basically a doubling. And Spain is next, and then Germany, England, France, Brazil. So what about here in California? Or I'd say there in California. Well, in terms of the CDC data, the number one, the state with the highest number of infections is New York, and then it's followed by California, and then Illinois, Florida, Texas, Georgia, DC. So you can see that 1,345 cases in New York and 800 in California. And then if you drill down into California, this is the California DPH data, you can see that we have, well, at least the state has 786 cases, and a third of those are in San Francisco. So actually the SFDPH website as of right now says 305 cases, but that was as of July 29th. And that was the day that San Francisco declared a state of public health emergency on July 29th, with a third of the cases. You can see here the data on the right side. This is really mostly occurring in biological males. There's 3 female biological females out of this 786 person outbreak in the state of California. So it really is, as Liz and another very excellent science reporter on Twitter keep on saying, call it what it is. This is a infection that is mostly affecting gay men, which, by the way, it's incredibly important to identify that so that resources can be appropriately targeted to that community. It's always the right thing. We've always done this in public health to say which communities are most affected. That's absolutely how we usually do things. Twitter is very distorted, and so is COVID, but this is not how the world usually works. If an outbreak is in a certain community, you want to define that community and get the resources there. So in terms of the symptoms, this is the largest case report of the infections. It was published in the New England Journal on July 21st. And so I think this gives a good idea of what the symptoms are. This is 16 countries. The median age was 38. 98% of these 528 individuals are gay or bisexual men, 75% white, and 41% have HIV. Mostly before this, the main manifestations of infection were always lesions, skin lesions, thus the pox. And they usually ranged from macular, which is flat, to blisters, which is called, it can be vesicular or pustular. And then they crossed over. And those lesions are a feature of this outbreak as well, except that importantly, the common anatomical locations of the lesions in 73% of cases are in very uncomfortable areas, which are the anal and genital region, speaking to the sexual nature of the spread. These lesions can be singular or multiple, but in 10% of cases, there's just a single lesion, which can be very confusing. It can look like herpes or syphilis. And then just like all of monkeypox, which is whether it was spread from rodents or in this case, there are usually systemic symptoms, and the systemic symptoms are fever, lethargy, muscle aches, and importantly, big lymph nodes is a clue to the diagnosis. And they usually precede the rash. And there was no difference in those living with or without HIV in terms of what the infection looked like. And, you know, I had to show you a series of these pictures from the New England Journal study, and there's also some pictures on the CDC website from the UK. But you can see that the lesions are very variegated, meaning they can start as macular, then they can go to vesicular, and they can be in different phases all at once. Like on one area of the body, in this case, the penis, there can be multiple lesions in multiple stages, and then you can just guess that it's uncomfortable. It's not just uncomfortable, it's painful. And it's really important that pain control becomes a part of management because these are such sensitive areas. So I wrote a piece on June 24th for The Atlantic saying the US is underreacting to monkeypox, and I'm finding myself really surprised that it's August 1st and we're still not in a very different position where that what I said in that article is testing and contact tracing, especially when we don't have very easily accessible tests. You actually have to unroof a lesion and then test it, which is much harder than how we test for other sexually transmitted diseases, where we can often ask the patient to do their own swabbing. We actually have to do this very complicated unroofing of lesions. And then, since the CDC was the only one doing the testing at the beginning, then they worked with LabCorp and Mayo Clinic. The tests were slow, and testing and contact tracing and masking and distancing and ventilation for COVID were always supposed to be strategies to try to reduce transmission to get to a vaccine. But the major part of this article and what people have been saying is we didn't have to develop a vaccine. Like we had to take 9 months to develop a vaccine for COVID. There was always a vaccine for monkeypox. That was the smallpox vaccine. So there's 2 types of smallpox vaccines. ACM 2000, which actually has a live component, so we don't like to use it in very immunocompromised patients. But the one that's really been pushed forward is Jynneos, which is an inactivated vaccine. And if we had much higher supplies of that vaccine, people wouldn't be waiting in line and protesting at international AIDS meetings and begging Ward 86, where I'm the medical director, calling up and saying, why, when are you going to get more vaccine supply? So it's been a very frustrating month. There was actually, many doses, almost 1 million waiting in Denmark, and the FDA in a bureaucratically slow way didn't approve them for quite a long time, even though EU had already approved them. So finally 786,000 doses are coming, but they're not here yet. And so if you look at the Kaiser Foundation website, you can see that every state is begging for vaccine. They have way more people who need the vaccine than they have vaccine supply. And really, even though the CDC at the beginning said, quote, ring vaccination or vaccinate everyone who's exposed, that's PEP, that's post-exposure prophylaxis. We actually want to vaccinate everyone who's an MSM who will accept the vaccine, because then we can give everyone in this population immunity and hopefully contain the outbreak. So there's quite a bit of discussion now about, are we going to be able to contain this? It's still pretty much within one community. We could, but we need the vaccines. Beyond the vaccine kind of fiasco, really, if people who have disseminated lesions or lesions in very sensitive areas, there is a treatment. It's called tecovirimat. Pox is its other name. But you can only get this through the CDC. We have actually gotten this for people at Ward 86, and actually the CDC, to their credit, has made it easier to get to care of tecovirimat when we need it. And then finally, in terms of the manifestations, I told you all of them. Out of 22,000 cases, there have been some deaths, though. It's actually rare because the majority of this outbreak is this West African clade, which is less virulent. But there have been 2 deaths reported in young men in Spain, 1 in Brazil, and 1 here in India. And then the more virulent clade is called, it used to be called the Congan clade, and there have been 75 deaths in Africa. So when we talk about vaccination, and this has always been true of ART access, for example, with HIV, we can't just stop at gay men in this outbreak. We have to think about what's been going on endemically in Africa and get vaccines to people in those areas. So I will stop here, but I wanted to give you all that kind of background for us to launch our discussion.
Thank you so much, Dr. Gandhi. Everyone, I want to apologize. It appears that we had someone invade our space and take over our chat. I don't know how they were able to clone some of us, but please know that that vulgarity will not be accepted and certainly was not our typing. And I apologize to you, Dr. Gandhi, because I was a little freaked out. So I missed a little bit of what you said, trying to frantically.
Oh, sorry, I'm just looking at the chat and seeing some stuff. Sorry. I kind of missed that whole thing.
And Liz, you were doing a really great job kind of going through as people were asking questions and addressing them. So with that, I guess to be clear, so the strain or the clade that we're seeing in the United States, that's the Congo clade, or does it have a different?
There are 2 different types of clades, and this is the West African clade. So it is actually the milder form. That doesn't mean doesn't mean that it's not hard to take and there isn't real pain, and there have been some deaths again. So but yes, the what's called the Congan strain is more virulent and has a higher mortality rate, the one in Africa.
And have there been any theories or like prevailing ideas as to why this current iteration of the virus seems to be so disproportionately targeted to the MSM community, particularly here in the US and Europe?
Want me to tackle that?
Yeah, please. Yeah, please.
Basically, it's, it has to do with the nature of sexual networks among gay men. A lot of I don't know what the percentage is, but many of the cases were the early ones in Europe and the North American cities were associated with people going to there was some pride events and a fetish festival and saunas, which are like bathhouses. So a lot of it was, people that had quite a lot of sex, men specifically who had quite a lot of sex. A lot of them reported having multiple partners very, very recently before they were diagnosed. And a lot of them had, other STIs indicating, sort of the level of sexual activity. So even though, sort of anyone can get monkeypox through close personal contact, it really is sort of transmitting in sort of not only just in one community, but it seems to be, these aren't just gay men going out and having coffee together, it's really very closely related to sexual activity. And one thing I learned today at the AIDS conference, there's a doctor in Nigeria who has studied, worked on the monkeypox situation there. And in 2017, there was a case there was a case in, monkeypox started to explode there. Previously, it had been largely seen among children. It was considered not very easy to transmit. Often people got it from animals, as Monica mentioned about the rodents. But in 2017, the outbreak there in Nigeria started to change. It became, it shifted to young urban men without any traditional risk factors. And the doctor, his name is, I'm not going to pronounce it right, probably, but Dime Ogonia is my guess. He's tried to warn people that, the virus had changed. For the first time, it was spreading through sexual contact. And this shift in transmission would make it more easily spread from person to person. There's a great NPR article out the other day about this. He tried to warn health officials that it looked like the nature was changing and it was spreading through sexual networks. But people told him to be quiet about that. And I think we sort of saw that here I'm in Canada, but in the US and in Europe, when this new outbreak happened in countries where it hadn't previously been reported, that people wanted to not emphasize too much that it was happening among primarily gay men, because we know the kind of stigma that comes with that. We saw it with HIV. So there was a kind of thing that kind of a real push from public health officials, advocates, concerned people in general that we want to just emphasize anybody can get it, anybody can get it, anybody can get it. But we're on going into the third month now. Everybody's really not getting it. It's 90-something% still among gay, bi, and trans and other men who have sex with men. There have been cases, as Monica noted, a few cases among children and some cases among women who my assumption is they're probably getting it from close contact. We know that gay men live in households with other people. They have family members that are outside that group. But I think what we're probably not seeing is we're seeing a lot of misinformation about how easy it is to transmit through fomites, through towels, through, a lot of people are saying it's airborne. But if it was transmitting easily through casual contact like that, we wouldn't be seeing the distribution we're seeing. It wouldn't be 99-98% men, because we all breathe, we all sit on the subway and touch the elevator button. Yeah, I think it's becoming increasingly clear how this is transmitting, and it may well be if what Dr. Agonia said is, based on what he said, it may well be that it had been transmitting through sexual networks in Nigeria as well. So it may not be as new of a thing as we think it is.
Okay.
That would be good to write up. But one thing I will say is that, like, once it starts in a certain network, this is a network, right, of people across the planet. So it's not that people are interacting with people outside their community at the moment in this sexual way. So it's right now staying within this network. And that's why it's so important to work on the health of this network with vaccines.
So Liz, what you just shared actually brings up two questions for me, because I definitely want to make sure we talk about the response to the outbreak. But I want to let everyone know you are still, those of you in the audience with questions, Angelina, our event manager, has tweaked the chat so you can send messages to her as the host, and she will get those to us. So please go ahead. The chat is safe again. Share your questions there and she'll make sure that we have them, and we'll get to as many as we can. So the first question that comes up, because this is so different from previous iterations of monkeypox, and particularly the transmission sounds like it's completely different. We're not talking about rodents anymore. It's sexual contact. Is it time to call this something else, like see that it is a distinct virus from monkeypox, just like monkeypox is distinct but derived from smallpox? Or am I misunderstanding how viruses are named? And then secondly, I think, Liz, you touched on how the public health response has been so cautious because of the mistakes and the lessons learned from before. But in your opinions, is that the right response, or should there be a more a louder, more targeted response from our public health officials? So totally two different questions. But
I mean, the thing about the virus, it is not like evolved or anything from smallpox. So they just all happen to be in the same family, like it's a relative of smallpox, and that's why the smallpox vaccine works so well against monkeypox. It's 85% effective, but they're totally two distinct viruses. And this monkeypox is just this unfortunate name. And there's been a lot of discussion about changing the name because it sounds so strange and it doesn't even have anything to do with it. So it was just in 1958, it was how it was named. So maybe they will change it.
But do you think
I'll
because
just,
this one's so different that this may warrant its own category?
Oh, vaccine. That's actually a great question. Like, is this monkeypox strain so different that Jynneos doesn't get it? I think Jynneos is very effective against it. It doesn't seem to be very different. There was always this kind of Congo Basin clade and then this West Africa clade, and it just like sequence wise, it looks pretty much the same. And like Liz was saying, maybe there was underreported sexual transmission of the clade in Africa. So it doesn't seem like it's different from that.
I would
so
agree with that. I
should get
think, there's a lot of debate about whether or not we should call monkeypox a sexually transmitted infection. And that's kind of beside the point. Most sexually transmitted infections can transmit other ways. And herpes you can get from skin to skin contact. Hepatitis C, which hardly anybody, outside particular communities thinks of as a sexually transmitted infection, but there have been outbreaks of sexually transmitted hepatitis C among gay and bisexual men for, since early 2000s. And it seems like, that kind of sort of contained outbreak within a particular sort of group can, occur simultaneously with the kind of transmission we're used to for a pathogen. So I don't think it's a different pathogen. I think it's just, it's got a network, it's gotten into a network that has offered it a fortuitous niche that it's finding it easy to transmit in, but I don't see any reason to think it's a new, a different enough virus to be called something different. And maybe Andy can address the messaging piece of that.
Yeah, hey y'all. I think there's definitely concerns around stigma that may emanate from the naming of the monkeypox virus and also the communities where it's currently presenting. So it's really important that our public health institutions balance, which requires a very delicate balancing act of making sure that the communities that are most at risk are getting the information they need to protect themselves, while also making sure that the response isn't stigmatizing to communities that are already vulnerable and marginalized. I also wanted to just briefly talk about the piece around what our public health institutions are doing and kind of the gaps, including bottlenecks that we're seeing from some of our federal public health institutions related to the public health response to the monkeypox outbreak. I mean, I think it's been pretty clear. Dr. Gandhi just mentioned, for example, vaccine access and supply and distribution and how there have been major fails at the federal level related to that. There were 1 million doses that were sitting in warehouses in Denmark. We had the vaccines that we needed at the beginning of this pandemic, at the beginning of this outbreak to really address this public health crisis. And we had it 2 months before, like 2 months ago, right? And now we're seeing numbers continue to climb. And I think that's the direct result of the fact that the federal administration and our federal public health institutions are not taking this as urgently or as seriously as they need to be. And so that's why we need to really push. And this also shows up beyond just like vaccine access, but you can also see it in terms of access to TPOX or treatment options. Dr. Gandhi also alluded to that just briefly about how the CDC has made it a little bit easier for folks to be able to access that. But really, it's still too hard for folks to really be able to access that treatment. We're seeing people who are experiencing really severe symptoms, who are in a lot of pain, and they're being, turned away from a treatment that is highly effective in treating this, preventing the transmission, and also being able to, alleviate symptoms that people are experiencing. And it's really outrageous that our public health institutions are failing at the level that they are in regards to this as well. Access to treatment should be something that anyone should be able to get very easily, not something that, requires an incredible amount of information and ability to be able to navigate complex health institutions and really be able to advocate for yourself. So I think these are a couple of concerns that we're seeing in terms of the federal bureaucracy and how we need to really address some of those concerns. Because what we're going to see is if we continue to have these types of barriers to vaccines, to testing, to treatment, this is going to take hold in really vulnerable communities, and we're going to see health inequities that arise that are mirroring already present health inequities in the communities where we live. So I think there's a lot of work that needs to be done around advocating for better responses, and we really need to push our public health institutions and our elected officials to be more responsive to this crisis.
Thank you, Andy. We have several questions from the audience. I just wanted to make sure we were clear on one thing. So in your presentation, Dr. Gandhi, you said that there's 786,000 doses of vaccine on the way.
On the way.
So there's
they're not
vaccine
even
production
here yet. They there was a promise that they were going to get here by the end of July, but now we're on August 1st.
Yeah.
So they're not here yet. I mean, it drew a lot of criticism. It was relevant to what Andy just said, but there were all these doses in this Denmark plant, and EU had already cleared it. The EU equivalent of their CDC had already cleared these doses, and we could have just gone on their clearance and said, bring them over. But instead, the FDA kind of ploddingly, bureaucratically took their time and had to clear it. And I think these are the kind of cutting through red tape things that we have to do with our public health infrastructure to respond nimbly to outbreaks. And it's that was very upsetting that we don't have these doses. It's very upsetting that people would wait for 9 hours in line in New York, or that people are clamoring in the clinic in which I direct.
So is this going to be something where like we now have to also be concerned about supply chain disruptions, because no one's saying that we can make this vaccine or we're producing it here in the US. Like with COVID, the vaccine is produced here, right?
I can address that. That was something that there was a protest about monkeypox access at the International AIDS Conference this morning. And that's one of the demands. I mean, first, let me just back up and say, being with, the global HIV community, really brought home to me that, as much as we complain about the 9-hour wait, people in Africa don't have access to these vaccines at all.
Yeah.
People in Australia don't have access. I talked to an activist there that said no gay man in Australia has had access to the vaccine. Here in Canada, in Montreal, they're giving it to everybody that that's attending the conference that wants one. They seem to have plenty. So it's really it's not all about us. The U.S. has developed the vaccines and, had a national testing network set up and stuff because they were worried about bioterrorism using smallpox. So basically the US and European countries have snapped up the entire supply, which means, as much as we think we should have access to more, most people around the world aren't getting access to any and really have no prospects to get any anytime soon. So this protest today, one of the key things is, to override some of the intellectual property and the patents to try to make this make it so that other manufacturers and other countries can produce this and enough for at-risk people everywhere in the world to have access. And I think it's also important to know, you see people that, because the messaging has been, anybody can get monkeypox, or you can get it from the idea that you can get it from, casual contact as easily as from sexual contact, means a lot of people that are at very low risk are sort of clamoring to get this vaccine. And it's important that, we direct the supplies to the people who need it most, who are most at risk. And that would mean, people at risk in Africa should get the vaccine before someone who is at no risk in the US gets the vaccine. And that wasn't how it worked for COVID. And COVID, we're getting, our third and fourth boosters when some people haven't had vaccines at all in much of the world. So this protest really emphasized that we can't let that happen again.
I'd also like to add on to that really quickly. Like, global health equity is such a key issue, and making sure that folks in other countries are able to access vaccines. As we've seen with COVID, when we don't address this as a global problem, this can quickly mutate into different strains and becomes much more complex for us to deal with at the global level and even in developing countries. The other thing that I want to just mention too, talking about from a federal public health response to this, the Biden administration is talking about mobilizing something around, 4 million doses or something like that by next summer. And the fact of the matter is we need a lot more. One of the things that's really frustrating is that we have bulk vaccine material that's enough for about 15 million doses. But there's not manufacturing capacity in this moment with the current folks that we're contracting with to be able to get those turned into individual doses in time. But what we need to see is a commitment from the Centers for Disease Control and the FDA and the federal government to really mobilize, to create a plan and to mobilize infrastructure to be able to do just that. And we also need to be thinking about the global impact and how can we make sure that communities outside of the US who are facing the spread of this outbreak and the spread of this virus can also be able to address it before it continues to spiral out of control. It is very possible for our public health institutions to really step up and figure this out and move forward if there's the political will and the urgency around responding to this. And we are just not seeing that right now.
Okay. So we do have quite a few audience questions. I'm probably going to do a little popcorning and just kind of pick each of you to answer them so we can try and get through as many as possible. So, Dr. Gandhi, do you think that there are more people that have monkeypox that aren't being tested?
That is certainly possible, but I will say that the one thing that has happened is the media has been really way better about it's been great about monkeypox, in my opinion. Liz and Ben Ryan and really great media experts, and that has brought awareness. And so people who have lesions are being tested. There is, I'll just tell you that our STD clinics and our clinic is just full. We are just glutted with people coming in for testing. So I do think people are coming in to get tested. I think, Liz, you reported on that women are still, it's not that women aren't getting tested. Like, if women have lesions, they'll be tested. And that's, our city clinic is just full. So I'm not sure bias is like, I don't think people are avoiding the clinic or anything. Like, it's kind of, they're very painful. 73% are in the anal genital regions. I think people are coming in.
Okay. This next question kind of piggybacks. So either Dr. Gandhi again or Liz, what is happening with bias about who gets tested? Certainly gay, bi, and queer men have sexual networks that go beyond gay, bi, and queer men. I know in my community, in Atlanta, there was definitely a huge issue of men who were having sex with men, but also with women. So this hits home. And the question, haven't seen much education about monkeypox outside of the LGBTQ community. Liz, can you speak a little bit to kind of the messaging and what's being seen in those the broader communities,
Well,
particularly
it's
like
the balancing act, Andy mentioned earlier. It's like we need to get information out to sort of the general public about, you know, what the symptoms of monkeypox are, how it's, how it's transmitting in the real world now, as opposed to how it maybe could theoretically be transmitted. And then anybody who is, you know, in close contact with people, which includes skin to skin contact. It could include, you know, breathing face to face, you know, other sorts of, you know, very close contact of the sort that, you know, family members, household members have with each other. That, you know, that education needs to go out to everybody. At the same time, we need to, you know, direct the education to the gay and bi and trans community that's most affected now. I think it was true early on that, you know, it was very difficult to get tested. You had to sort of qualify to get tested. You know, they would only test people that were within certain groups or had, you know, certain risk factors. Early on, it was, you know, people who had traveled were the only ones that could get tested, traveled to a place where monkeypox had been. But as the testing has expanded, a lot of those restrictions have gone away. The CDC does urge anyone who has, you know, lesions, and I would say suspicious lesions, but the monkeypox now is manifesting in so many different ways that, you know, it can be, you know, it doesn't always look like, you know, the pictures of the African children you saw in the early news reports. And they can, as Monica said, look a lot like a common STI. And we know, you know, gay and bi and trans men are more likely to use sexual health services. They are often used to getting regularly tested for STIs anyway. So I do think it's likely that they are more likely to have been tested, which could have shifted the, you know, the case distribution somewhat, especially early on. But, you know, like I said, we're 3 months into this now, and a lot of people are aware of it. Clinicians know what to look for. Members of the general public know what to look for. And, you know, some of these symptoms are so painful that they're not really going to fly under the radar. So I think at this point there was a study in the UK that, you know, looking at how many people they tested, or the proportions of people they tested, and it was something like, don't know the numbers offhand, but it was a high percentage of the gay men who got tested positive, and it was something like 2% of the women that got tested positive. And I'm aware of someone who runs a lab in down near LA, and they're developing a saliva test. And he told me privately that, you know, they tested about 30% of the people they tested were women, and none of them had been positive the last I heard.
Okay. Wow. Sorry, this is a lot. Someone, you had mentioned earlier, the previous sort of vaccination protocols that were in place when the world was battling smallpox. So someone was asking if you all could expand or repeat on the effectiveness of the childhood smallpox vaccine against monkeypox. And I guess a question that I have, is smallpox still part of any sort of vaccination regimen that I
No.
was, so the,
I mean,
this
it's really gone, except for like 3 or 4 labs that they have like vaccine stock, and that would be the formal definition is eliminating in an area. So we eliminated it in the US 1970. That's why we stopped most of our vaccination around 1972 in the US. Then 1980 was eradicated worldwide. And then extinction would be if we took these couple of places where there was some smallpox stock and destroyed it, which they have not done. So data from Africa shows that the smallpox vaccine is about 85% protective against monkeypox. So in that large 2003 outbreak that I told you about, from the infected animals imported from Ghana that got into the prairie dogs, there were, out of 71 people, there were 8 who had received smallpox vaccination, but everyone else hadn't. So it is, I mean, it isn't like 100% protective, but it's at least 85%. It's as good as it gets. If we think about the current effectiveness against any infection of the current COVID vaccines, we certainly would approve an 85% effective product. So it's good. And it's certainly better than waiting to make some very specific vaccine to monkeypox. So it's as good as it gets. It's there. We need to just, you know, like Andy said, get it produced and get it out to people.
I'll just add to that. There was one quite recent study out of the UK where they you know, they looked at a case series of people with monkeypox, men with monkeypox, and 9% of them had previously received a smallpox vaccine. So I think it's, you know, it's very effective, but it's not, you know, 100%. So someone who was vaccinated
Yeah.
as a kid, you know, like I was decades ago, the immunity may have waned. And I think one important issue coming up now is that there's some debate around whether, you know, 1 or 2 doses. A lot of places, including San Francisco, are giving 1 dose first, so more people can get at least some protection as soon as possible. But you know, it is a 2-dose regimen. The FDA is very firm that it should remain a 2-dose regimen. People living with HIV especially don't appear to respond as well, so they should probably be prioritized for second doses. But yeah, I think you know, if people get 1 dose of the vaccine thinking they're going to be protected, and then you know, go resume whatever behavior they were doing before they got vaccinated, we could have a problem. So I think more research is needed on that.
Okay. And you actually kind of dovetail very nicely. So are people who live with HIV at higher risk for severe complications from monkeypox?
Not according to the largest study. Actually, it was people with HIV and without HIV had similar clinical manifestations. And there was another BMJ study out of the UK showed the same thing. So that's a lucky thing. I mean, many people mostly in these case series have well-controlled HIV, but they don't seem to have different manifestations.
To the extent that there's a silver lining, I think we found it.
Yeah. Yeah.
Okay. So talking about trying to track where this is going, why hasn't the Department of Public Health started contract tracing?
I mean, actually, I don't think they were trying not to. It's just like it was part of the initial, you know, testing and contact tracing was our initial ways to try to contain, but it quickly went to kind of first a ring vaccination, which is anyone who's exposed to the virus, exposed to someone with monkeypox, get the vaccine, and then PrEP as opposed to PEP. But it's not that they've abandoned, to my knowledge, unless Andy and Liz know something differently. You know, this is actually true of all STDs. You're supposed to report if you're willing, you're supposed to report your sexual contacts and contact trace.
Right.
Okay.
And you know, it's quite difficult. You know, if somebody's had sex with, you know, a large number of people in a group setting, maybe, or has gone to a large gathering, or doesn't know the names of all their partners, it's very hard to do that kind of tracing, obviously. So what some of the venues have done here, they've said, you know, like you know, a couple of big dance parties around Pride, and one of the, you know, the bathhouse in Berkeley has said, you know, they've notified all their patrons that there has been a known exposure at that event, and the DPH has made anybody who was there eligible. You don't have to like know the specific, you know a specific individual that you may have gotten from. It's just they're saying, you know, anybody who was in that setting is considered
At risk. Okay. Okay, trying to go through them in order, and I think I'm out of order. What precautions should be taken to protect from transmission? And Andy, one thing that you and I talked about beforehand was the importance of shifting to telling people what they can do as opposed to what they shouldn't do in order to really influence, you know, transformative, you know, a behavior change. So what can people do? What precautions can they take to protect themselves?
Yeah, that's a great point, and thanks for that question, Precious. We actually have a really great guide that the AIDS Foundation's created with a lot of messaging that's based in harm reduction and a sex positive perspective. We know that it's really important not to stigmatize folks, and that folks are going to want to connect with each other, especially after 2+ years of experiencing social distancing from a previous global pandemic. So what are some ways that folks can connect with each other safely? Well, I think the first step is to really share with people the reality of how this virus is transmitted, as has been shared, you know, by Dr. Gandhi and Liz. You know, this is something that is spread by skin-to-skin contact and largely with intimate connections with each other. This also can, include kissing, cuddling, all kinds of things like that, and direct skin-to-skin contact. So, we put out a guide with a lot of other safer sex practices, as well as other ways to reduce risk that the community members can use to help protect themselves. This includes, just having very real conversations with partners that you are, being intimate with, which our community is really good at this. We've developed this experience based on HIV, and so we are very responsive to taking, responsibility for our own health and for, showing up to protect one another as a community. Yeah, so I highly recommend folks check out our guide. There's also really great tips in there. And stay tuned as we continue to learn more about this particular virus and the way that it's presenting in this moment.
Thank you. Would you all care to add anything to that? It was pretty complete. Thank you so much, Andy. Okay, so someone is asking, can people transmit the virus before their rash or symptoms appear? Or other symptoms?
It is easier to transmit with active lesions. There has been some asymptomatic transmission. And in fact, a lot of people are looking at saliva testing. If we had like testing before someone had active lesions, this would be really helpful. But the majority of transmission is really with active lesions. So it's kind of like, you just choose. I mean, people are not going to likely come in before they have lesions anyway. So.
Okay. And another question for you, Dr. Gandhi. How many doses does San Francisco, and if you can speak to the whole Bay Area, that'd be great, need to prevent monkeypox from becoming an epidemic here?
Yeah, that's a very good question. Liz will probably know better. I mean, I know that the estimate for the country is 1.5 million men who would be qualified for PrEP, plus every man who's living with HIV, right? Because then you're kind of, so maybe when Andy said 4 million doses, that's maybe about right for 2 doses for every person, but it's very terrible to think that those doses would come by next summer, Andy, you said, because that's very late for getting, the number of, we need to get those 4 million doses out like now. But so then in the Bay, so in San Francisco, maybe Liz will know better in terms of numbers.
I don't know. I've heard the same method of estimating, going by that are using PrEP and that HIV positive. I would probably also, I've seen, certain healthcare workers added. SFDPH includes all sex workers of any gender and orientation. I believe they include all transgender people, or maybe only transgender people who are in the same sexual networks, but it's a little more expansive than the PrEP indication, but still, I think that would be a good estimate. I like Monica, it's like I know it for the country, but I don't know what that number would be for San Francisco.
Okay. And we actually already touched on this question about 1 dose versus 2 dose. I think, Liz, you talked about how the FDC is being, or FDA, sorry, is being so strict on the 2 dose regimen and the spacing and all of those issues. So it looks like that's actually not a question. I think maybe one of you sent a response to Angelina and she posted it about not seeing.
I mean, I would just say, I find it annoying when the CDC is strict about that, because it just makes sense to me to get, absolutely, I totally agree with Liz. We want that 2nd dose, but it's actually been shown in all vaccine campaigns that the longer that you have between doses is just a principle of vaccinology. The greater the immune response you get. It's the prime and the boost vaccine should be far apart. And I'm sure it was expediency in the setting of something as horrible as smallpox that they had 4 weeks between doses. But I just see no problem in giving everyone 1 dose and absolutely following up with the 2nd, but getting more 1 doses to people. This is something the US would not do with the COVID vaccine, even though India, US, UK, Canada, India did with that COVID vaccine. They absolutely saved lives to get the 1 dose in first. So I don't like the strictness of the CDC saying it has to be exactly so.
Okay. Well, it is 12:59 and we want to respect everyone's time, but I would like to give each of you a chance if there's something else you want our community to know, something else that you're following specifically, or just a closing statement, for lack of a better term, this is your chance. Liz, why don't we start with you?
Okay, I guess I'd say that, while we know monkeypox is not a gay disease, there's no such thing as a gay virus, have sexual orientations, but we know what community it's affecting now, and it's been great to see that community step up and educate each other and produce safer sex material and do forums and outreach at Dory Alley Fair. And I think people who aren't in those networks where they're at risk can support those who are. And I think that's probably a better use of your better use of your time than worrying about whether you're going to get monkeypox from a toilet seat. If we direct the vaccines to the people who are where to the networks where monkeypox is spreading now, that's the best way to keep it from that's the best way to protect everyone else as well.
Outstanding. Andy, any closing thoughts or statement?
Yes, I have two really quickly. I want to say that, we as a community should be really outraged and frustrated at all the red tape and bureaucratic bottlenecks in terms of the federal response from our public health institutions. And it's time for us to step up and to demand more of these institutions. And I want to just share with folks two ways that you can make your voice heard and be part of this fight. And so the first is you can sign our petition. We are petitioning the Centers for Disease Control and the U.S. Department of Health and Human Services. And we have three demands. Our first demand is that we must immediately increase access to vaccines, testing, and treatment. The second is that we must ensure equity in the public health response so that race is not a barrier for anyone trying to access health care. The third demand that we have is around fighting stigma in the public health messaging, which means that we want harm reduction-based sex positive messaging that acknowledges that people are going to connect with each other and that they need information about how they can do so as safely as possible. So folks can sign that petition by texting in prevent monkeypox to the number 52886. And so again, that's two words, prevent and then monkeypox as one word, to the number 52886. You'll get a link, follow the link, sign our petition, get involved in the fight. We're also going to have an activist town hall this evening at the AIDS Foundation, 1035 Market Street from 6 to 8 p.m. It will be virtual and in person. And we're inviting folks from the community to come learn more about the gaps in the response and how we can advocate for better solutions for our community.
Thank you, Andy. Dr. Gandhi.
Yeah, I would just echo everything that both Liz and Andy said. Thank you so much. And I would also wonder, I think the media is doing a great job, but what I'm worried about is that if Biden could get monkeypox, and we may have moved faster. So we need to also just put in perspective that is there something so slow about this response because it's in a traditionally stigmatized community, and that is absolutely our role in HIV to fight back against slow responses. We had that in HIV for way too long.
Thank you, Dr. Gandhi. Thank you, Liz. Thank you, Andy. And thank you to everyone who joined us today. I hope you agree that there was a lot of information shared, but a lot of clarifying and sort of sorting through all of the reports that have been written up and shared about monkeypox. On behalf of the team here, thank you all so much for making this possible. We are especially grateful to our community of sponsors who allow us through their monthly contributions to provide these sorts of programs, to pivot literally on a dime when the community needs us, to provide this platform so you all can be better informed and you can go and act and volunteer and get involved on behalf of your friends and loved ones. Please check us out if you're interested in sponsorship or want to find out about our upcoming events. Go to welcometomannys.com. We have our events listed there, and you can become a sponsor. I do want to let you know that our Summer of Learning series continues tonight. Very excited to welcome the Dean of the Berkeley Law School, Erwin Chemerinsky, will be coming to provide his evaluation of the Supreme Court of the United States and their 2022 term. We have a lot going on here. If you all have additional questions about monkeypox, please feel free to send them to us. You can send them to me at precious@welcometomannys.com. I'm happy to forward those on to our panelists. And panelists, you all mentioned a lot of valuable resources, articles, and what have you. If you want to share those with us, we'll make sure to include them in our follow-up with everyone who registered on Eventbrite. So with that, thank you all so much. Dr. Gandhi, thank you for calling in from India. Liz from Montreal, Andy from outside somewhere. We just really appreciate your commitment to community and information, public health, and to all of us. Thank you all so much. Everyone have a great afternoon.
Thank you.